G'day, welcome everyone, and it is another fine Wednesday evening. My name is Kane Treble, I'm a GP based out of Mildura, far northwest Victoria, and we are here for some exam preparation. Good to see some familiar faces in the chat already, always good to have you here. And best of luck when you get those CC exam results come through to me. Thinking of you, and I'm sure you've smashed it, mate. I know we always come out of those exams second guessing ourselves, but I honestly think you'll be fine. Of course, we are here this week for some KFP preparation, bringing it back to where I originally started these live streams from, doing KFP exam preparation. So I am a RACGP. I am working currently in the GP space, and I want to make sure that as many people as possible get through these exams, because I'll be honest, they're not fun exams. And I know there's not a whole lot of free resources out there, and so I wanted to do something to make a difference, to put some stuff out there. So hopefully this is helpful to you. So of course, why should you listen to me? We are 52 days from the 2025.1 KFP exam. We have that countdown happening as we do every single week. Still plenty of time to get things ready, but I want you to be using this time smartly. I want you to be thinking through how you're approaching the next 52 days and aiming towards your exam focus. So as I've said, I am a FRACGP from Mildura, Victoria. I'm a father. I've got 2 kids, 6 and 3, so I very much appreciate the difficulties of trying to prepare for these exams with young kids. I'm a husband as well, and a nerd as well, so thus live streams seem like a good idea. I also struggled initially to get through these exams. I had a lot of life things happening at around 22.2, and so I failed. And I thought, okay, that's fine, I'll just reset, it'll all be good. Sat in 2023.1 and failed again. It was only then that I really sat down and kind of said, hey, what am I doing wrong? How am I approaching this? And I realized, as I think many people do, that this is an exam that isn't necessarily about what you know, it's how you answer the questions. And they're wanting the answers in a very particular style, very particular format, and I think that's something that mucks a lot of people up. So I want to make sure that people don't make those same mistakes that I made, and that you get through these exams on your first attempt. So really we need to understand the exam format and the requirements. This is a handwritten exam. We have actually got confirmation now that it will be in the same handwritten format. There'll be 1 line, 1 mark, 1 answer. And this is to avoid the biggest trap people fall for, I think, which is overcoding. That's giving too much information per response, which actually loses you marks. I want you to also know how to use the MCQ answer sheets as well. If this isn't something that you've had much experience or practice in, you probably want to be getting your hands on some practice ones before the day so that you're not getting into the exam not knowing what it is you're doing with those sheets. And of course, practice your handwriting. If you're not handwriting things now is the perfect time to start, because 4 hours of non-stop writing is crap. There's no other way to put it. And so you really need to train up the muscles of the hands, given most of the time we're typing things these days. A lot of us have fallen out of the habit of actually doing writing. And so I want you to be writing things by hand and building up that strength. And of course, no abbreviations. I cannot stress that enough. Yes, it's clinicians marking the exams. Yes, they try and use some common sense, but the rule from RACGP has come out that if you use abbreviations, they'll pretend as if you have not written whatever it is you've written there. So best thing to do not use abbreviations at all. Now, of course, there is a complete study syllabus for the exam available through RACGP. If you haven't gone onto GP Learning and gone through those modules, do it this weekend. Make some time to do it, because it will spell out exactly what is on this exam. Try not to use this time left, this next 52 days, to try and learn new things. Instead, I want you to be practicing questions to identify your weak areas and use these resources like GP Academy, ModMed, KFP Bank. Use them to hone in and perfect your skills in those particular areas and in the answer formats that are going to work best for you. Bearing in mind that this exam does want you to be answering in a particular format, and that's one of the things we're going to train you through these live streams. You also need to really focus in on your time management skills. I want you to be practicing about 2 minutes per question, and that allows you time to get your answers down, write them out, but also to leave you with a little bit of time at the end of the exam for reviewing and revising those answers. If there's things that you aren't so confident on, figure out now how you're going to flag those and come back to it. it's so important to actually remember to come back to it. You don't want to be missing marks because you've forgotten a question. So make sure you've got something really nice, really obvious, and try and have an answer for every question. Even if you're not entirely sure, try and actually get that in there. I can see some comments coming through from the chat here. Which question banks are the best? If we jump back to here. So I personally have done GP Academy and ModMed. And to be honest, I actually found them pretty comparable. I think the real thing is not so much what questions you're doing, just do questions. And I'll show later on as well, we've built a little tool that you can use to try and turn the consults you do in the clinic into practice questions as well to try and prepare yourself. So really, KFP is about mastering the case analysis, trying to work out what is that question they're actually asking us. Practice writing out the clinical summary. The AKT focuses in on what is your clinical knowledge. Do you know ABC? Now they want to know, can you actually apply this to patient conditions? So yes, they might have cases that at first glance look very simple. You just go through ABC. But what they want to start teasing through is what are those particular relevant case points and prompts that actually change that response, that tailor the answer through to that patient written down in front of you. So make sure you are actually answering the question being asked. Don't just see COPD and start regurgitating COPDX. I want you to be thinking, okay, this patient in this circumstance needs this management plan or investigations or whatever the question is. So with this, ask yourself, what is the question actually asking? If it's a history type question, what would you actually ask in the clinic? And try and think through then, how would you format that in the KFP style answer response? For examination, what are you actually looking for? If this patient was sitting in front of you, what are the things you're actually going to be examining for? If they're asking about what is the most important diagnosis or condition not to be missed, it's those serious things, those red flag conditions that you cannot afford to miss at all. If they're looking for the most likely, it's the probable diagnosis. If we're going back to the Murtaugh model style approach. For initial investigations, you're looking at those simple, almost bedside style, inexpensive first line tests you can do very quickly. Whereas if they're asking about what is the best diagnosis tool, they're looking for that gold standard, and it's usually MRI, let's be honest. And of course, if they're looking for an immediate response, fall back to your DRS ABCD. If you get stuck and can't think of a specific management plan for that scenario, DRS ABCD will get you out of trouble every single time. And more often than not, it's actually the exact answer and the exact kind of format they're looking for, because they want you to know that you have an approach to these kind of situations should they arise. So always remember the traps of the KFP, the things that muck people up again and again. It's the answer the question being asked. Be specific and concise. Try and have that one line, one answer, one actual bit of content in there, one mark. Avoid the overcoding. So if you're going over and giving more information, you will detract marks from the overall exam, and of course, the no abbreviations. Let's have a look at a practice case we have here. Oh, that's great formatting, Kane. There we go. That's a little bit easier to read. So here we have a case that a practice question we used a few live streams back. We have a 55-year-old Caucasian male presenting with persisting cough and shortness of breath for 3 months, occasional wheezing, chest tightness, lifelong smoker, 1 pack of cigarettes per day, a history of hypertension, takes some lodipine, and no known allergies. Breathless, audible wheeze. This is a pretty garden variety type patient. And I think a lot of people would enter this kind of scenario and say, for this question, the condition settles, further testing confirms your primary differential diagnosis, classifies it as mild, so COPD mild. What initial management options would you recommend for John's condition? Provide 3 appropriate responses, dosing is not required. A lot of people might fall for the trap of saying SABA, send to physiotherapy, smoking, GP management plan. And here's the thing, if the patient's in our clinic, pretty much exactly what we do. This is the kind of response we'd have, and we would assume, being clinicians marking the exam, that they would understand what we're saying when we're writing this out. Unfortunately, this would muck you up completely. What we really should be saying, instead of SABA, again, we're using an abbreviation there, commence short-acting beta-agonist inhaler for symptom control. So here we're saying that we're starting medication. What are we starting? It said we don't need to worry about doses. Whew. If you aren't sure about spelling of certain words, they're happy to forego like spellings as long as they can work out what you're trying to say. The things they'll let go and the things they hold on to, don't ask me. But also they want to know why you're starting that medication. So specify you're doing that for symptom control. Instead of saying send to PT, we would actually be saying referral to physiotherapist for pulmonary rehabilitation. We're spelling out physiotherapist, avoiding that abbreviation, and we're specifying why we're sending them there. Now, if you want to get real good marks on this one, you could put standard referral, or if you're concerned about them, you would put urgent referral. So giving that qualifier there of the time frame in which you believe they need to be seen just adds that a little bit of extra polish as well. Smoking, pretty vague. You're saying you should be smoking? No, we're going to be encouraging smoking cessation. And of course, for GP management plan, you wouldn't do that as part of this question, because if we look at it, the thing says, what initial management options would you recommend? And a GP management plan isn't really a management option. So instead, you would consider something like ensure patient is immunized against influenza. So if we go back to our previous answers then, we would see that we've actually used abbreviations, so we're not going to get the SABA. Send to PT, again, we've used an abbreviation. There's no real context there. You'd lose marks there. Smoking, if you had a generous assessor, you might still get a mark in there for that one. But we can see we've actually lost marks here for the GPMP. Now, if you read the thing, it's provide 3 appropriate responses. So this is a common trap for people to fall into, and they actually have overcoded and would lose a mark from there. Let's go back to our preferred answers, and here we've got a mark for our first one, a mark for our second, and encourage smoking cessation, so important for COPD patients. So again, weighting our answers, acknowledging the most important bits, 2 marks there. Hopefully that makes sense. Now, we are going to have a whole bunch of these types of questions coming up, and I'm going to be running these live streams every week to try and give you as many cases as possible to practice. I generally give 3 cases, 3 or 4 questions per case. And we give you 2 minutes of reading time for these cases so that you actually have a chance to put some answers down. Now, get yourselves ready, because I'm about to load up the first question for our first case, and I would love, love, love it if you are happy to put yourself out there and put the answers you would put in the exam into the chat. Try not to read the chat if you're putting your own answers in, so we don't just have people copying off each other, but try and stick to that formatting. Try and word it the exact same way you would for the exam, and we can go through and we can have a look at what some of those answers are. Of course, we have some practice questions for you tonight, so you have 2 minutes on the clock and your time starts now. All right, that time is up, and we've got some answers through from the chat as well, but the answers that I would suggest for this kind of thing, and I'll always give more answers than are actually requested here, just so you're aware. This is also what you'll see in the exam as well. They're going to allow for a variety of things, and to get a sneak peek as well, you can see some of these answers are actually grouped together. So sometimes they will take one answer but not another answer if it's too similar, if that makes sense. That's called grouping. So here, three most likely differential diagnoses. These are our probability diagnoses then. We have impingement syndrome of the right shoulder. Again, we're specifying the side as well. And you'll note that actually gives you 2 marks as opposed to just saying impingement syndrome gives you 1 mark. Likewise, adhesive capsulitis of the right shoulder or versus adhesive capsulitis. There we go. Good tongue speak good. Now, I should point out actually there, impingement syndrome should be group 1 at the top there. That's a typo on my behalf. Rotator cuff tendinopathy of the right shoulder versus rotator cuff tendinopathy, or just tendinopathy would probably be less marks again. Glenohumeral, oh man, this is fantastic. Glenohumeral osteoarthritis of the right shoulder. This is why we use so many abbreviations. We get tongue-tied ourselves. Of the right shoulder, 1 mark versus just saying osteoarthritis, probably only half a mark there. So having a look through from the chat, we've got acute right subacromial bursitis, fantastic. Acute right supraspinatus tendinopathy, fantastic. Acute right C7 radiculopathy. Yes, actually, that would fit with this clinical picture. So I think you probably would get a mark there. It's not on this marking rubric, but again, if enough people do provide an answer, they can add it to the marking rubric there. I would probably be expecting a bit more kind of a shooting description or a little bit more of a nerve description, but it's not impossible. And so, yeah, I think they probably would give you marks there. And here we have a response from Nida as well. Capsulitis of the shoulder joint. Very good. Again, just try and specify the side. I know it sounds ridiculous, but you really need to spell everything out. Subacromial bursitis, yep, fantastic. And rotator cuff syndrome, fantastic, very good. So good answers. If you want extra marks, throw in the side. Easy marks to pick up. So look, guys, you're off to a good start. Very good to see such fantastic answers here. Well, of course, we've got another case up here. So let's get another 2 minutes on the clock, and next question starts now. All right, another question down. Let's have a look at some of the answers here. So again, the non-pharmacological management options, more marks for education on the natural course of adhesive capsulitis. So reassurance that with conservative management, often the outcome is good is a really important part of counselling for this condition. And that also applies if you do put, say, frozen shoulder or some of those other diagnoses from that last question. Likewise, if you just have it a little bit less specific, so education on the importance of mobility exercises, you're probably going to get less marks there. Active, gentle stretching exercises targeting shoulder range of movement is going to get you the most marks, or just, again, simplifying that down, passive stretching exercises to improve mobility, less marks there. Now, tied into that would probably be things like referral to physiotherapy for stretching exercises. And I think that would be in that same kind of bracket, same category of marks, depending on how much detail you put in there. Now, for this as well, we're also looking at providing some symptom relief. So application of ice packs to the right shoulder for pain relief would also be worth something. Heat application to relax muscles around the shoulder, less marks in this kind of chronic time frame. There's a little bit less evidence for heat, but some patients still find some relief from it. And of course, recommend avoidance of exacerbating activities. If this is something that is exacerbated by regular activity, they probably need to do some modifications to avoid those recurring injuring activities that are potentially prolonging this condition. Now we have here from the chat, side sleeping pillow, and that would probably fall under that recommending avoidance of exacerbating activities, I'd say. So yes, you would get that mark there. Physiotherapy referral, yes. Again, if we want to really stretch this out, you can put regular physiotherapy referral for stretching exercises, and you probably wouldn't get an extra mark for avoiding regular aggravating activity. And part of that is that you need to diversify answers. So there's probably a little bit too much overlap between the side sleeping pillow and that. And I think that's an answer for the last question. I'm very sorry. And up here we have physiotherapy referral for improving range of motion and strengthening exercises. A good one, but I would just be very careful. You may have just gone into overcoding when specifying improving range of motion and strengthening. So if you're finding you're using that and or if kind of thing, if you're having joining words, you're probably giving too much detail and you would actually lose marks. I know it is crazy. An exam where you lose marks for showing that you know what you're talking about, don't get me started. But this is the trap that most people fall for. So catch yourself in those ones. Shockwave therapy. Yes, actually, there is evidence for that, and so it could be something worth trying. Platelet-rich plasma injections. The evidence for that is actually much less, and the college is actually cautiously steering people away from that at the moment. It's also so close to kind of, could it be considered a pharmacological management option? I would probably avoid that for this question. But in terms of management options, again, it is something that a lot of people could suggest, but I would probably stick to less kind of therapeutic injection kind of things, if that makes sense. It's a bit of a no man's land, and so if there is any doubt, I'd probably hunt for other potential answers there. But otherwise, fantastic responses, and good to see so many people jumping in the chat as well. Of course, we have more questions up here, so let's get another 2 minutes on the clock for question 3. Time starts now. All right, and we have some answers. So sometimes you'll come to these questions where they seem to have taken a step forward, but then want to actually go back. And so it might trip you up sometimes, might break up the flow, and sometimes it's because one question might lead into answers for the other, or vice versa. Sometimes it's just random and we have to deal with it. So, in terms of what investigations are appropriate to confirm the diagnosis, the specific wording of this question doesn't specify initial or best. It's intentionally vague to give you a wide range of possible responses here. And so here we have things like plain x-ray of the right shoulder to exclude something, fracture or osteoarthritis. I think as long as you're specifying something sensible there, you would get the mark. Again, look at the detail there. It is just plain x-ray of the shoulder, of the right shoulder to exclude. So we're giving what we're doing, where we're doing it, and why we're doing it. If you were to just put shoulder x-ray, yes, you'd probably still get a mark, but you're missing marks there. So always try and be as concise but specific as possible. Likewise, ultrasound of the right shoulder to assess for rotator cuff tears. Again, something sensible in there will get you the marks. Magnetic resonance imaging, avoiding the MRI abbreviation of the right shoulder for detailed soft tissue assessment. And blood tests. So I think as long as you're listing something sensible with a rationale for it, you would get a mark. You would only probably get one blood test listed there. You wouldn't be able to get multiple. Coming in from the chat, we've got physiotherapy. Oh, I'm getting some of the old ones still through. Here we go. So from the chat, we have ultrasound of right shoulder. Excellent. So definitely yes. Again, try and go to that next level and specify why you're doing it. So what are you actually looking for? And ESR, fantastic. Again, I'd be specifying why you're looking for ESR, and again, avoiding the abbreviation. So spell out, as painful as it is, erythrocyte sedimentation rate. But yep, very sensible things. Now, the question did request 3. You've listed 2. If in doubt, take a wild guess. You won't lose marks for a wild guess unless you overcode. So feel free to always give something a random crack and see. You never know when you might catch an extra mark. All right, no other answers in the chat, so let's go to the next question. This case actually has 4 questions to it, so let's get 2 minutes on the clock and your time starts now. All right, so let's go to those answers. And again, you'll find these are all things we see in day-to-day general practice. They're not trying to throw too many curveballs at you. So what would you do if a patient's failing conservative management? You would step it up. So for this, you consider urgent referral to a physiotherapist for supervised rehabilitation, assuming you haven't done it already. And depending on what you had put for other answers, you may not get extra marks there. Non-urgent referral to orthopedic surgeon for surgical evaluation would certainly get you marks, again specifying time frame, who to, what for, and referral to a pain specialist for chronic pain management. Probably less marks in terms of overall how good is that response, but certainly an option. Now, from the chat here, we have radiology for ultrasound-guided cortisone injection. And yeah, truth be told, that is something that I think could be considered at this point, and I would dare say enough people would put that as an answer that it would probably be added to the marking rubric, and you would get the marks there. Again, really like that you've specified what you're doing and what for. I will catch you out on US guided, spell out ultrasound. I know it's pedantic, I'm so sorry, but you just have to do that for this exam. Excellent. So that's case 1 down. See, they're not so scary. You guys got this. Now we have 3 cases prepared tonight. So let's get to case number 2. Let's put 2 minutes on the clock and your time starts now. All right, so case number 2, let's look at those answers. I always try and get a few of these kind of women's health questions in early into the exam prep because I want you to identify quickly, is this an area that you need to do a bit more study, a bit more work in? It's something that I think a lot of GPs, a lot of male GPs in particular, might need more effort in, shall we say, to get through the exam. And so I'd rather we flag this early and make sure you know your strengths and your weak spots. Now, there's always going to be an abnormal uterine bleeding or vaginal discharge type question. It's just one of those almost given kind of things, so prepare for it. Know what you should be looking out for. And so what are our 3 specific differential diagnoses here that we are looking for? Trichomoniasis with that kind of history, it's the most likely, it's the probability diagnosis there. But of course, you can't really differentiate at this stage. So the other things we would be looking for would be bacterial vaginosis, vulvovaginal candidiasis, chlamydia, Neisseria gonorrhea, cervical ectropion or polyps, malignancy, less likely but not impossible, and fistula as well. Again, less likely, not impossible. If you aren't familiar with the Australian STI management guidelines for use in primary care, it is the Bible for STDs and STIs. Just go check it out, read it. It's a fantastic resource that I hope everyone's familiar with. Let's have a look through the chat, of course. Because here we have from Demir, vaginal candidiasis, fantastic, acute gonorrhea vaginitis. Pardon me. Yep, fantastic. Yep, gonococcal infection. From Dr. Baba, we have gonorrhea, bacterial vaginitis, and trichomoniasis. Fantastic. Good. So you can say trichomoniasis Otherwise, trichomonas, you would probably need to specify trichomonas infection. I know it's, again, pedantic kind of things, but these are things that kind of catch people out. And now is the time to find this out as well. But all fantastic answers there. Of course, we've got a question 2 for this case. So let's have a look. 2 minutes on the clock. And your time starts now. All right, time is up. Let's get to those answers. So what investigations are we going to do? Again, this is taken directly from Australian STI management guidelines. We're going to be doing either a endocervical swab or self-collected vaginal swab or it should be high vaginal swab for Neisseria gonorrhea nucleic acid amplification test. Same thing for trachomatis. Same thing with or without first pass urine for trichomonas. A urine microscopy culture and sensitivity would also be 2 marks. High vaginal swab testing for microscopy and gram stain, 2 marks. Whiff test, less commonly these days, but it's still part of workup. And to be honest, the evidence for it depends on which source you go to. Is a bit touch and go. Really, you need to be adding the right reagents at the spot. It is an accepted mark, but it's probably not something we tend to do as much in clinical practice these days. And of course, you can do high vaginal swab pH testing, which would still be definitely worth doing and worth a mark as well. pH over 4.5 indicates bacterial vaginosis. Let's have a look at the chat then. We have here high vaginal swab for gonorrhea PCR. Be careful using, I know, I'm sorry. Be careful using PCR. You can use polymerase chain reaction or really these days the test is nucleic acid amplification test. High vaginal swab for trichomonas, again, perfect, fantastic. Urine microscopy, fantastic. Culture and sensitivities. Yes, yep, beautiful. Love those answers. You probably need one more though, because we've got the gonorrhea, we've got the trichomonas, urine microscopy, culture and sensitivities is probably all lumped into that one answer, given it's ordered as one test. So opportunity for another response in there. And from Demir, we have high vaginal swab, trichomonas PCR. Again, spelling that out. HVS chlamydia PCR. You're getting lazy, man. You know, you should be writing it out. That's all right. And gonorrhea, you've got the same thing there. And microscopy for Candida. Yep, fantastic. Good. Again, probably need to expand that out because we have the option for 4 specific investigations there. But of course, we have another question here. So let's get another 2 minutes on the clock and your time starts now. right, so let's get to those answers. So we've confirmed here, yes, we're dealing with trichomoniasis. We need to know what are we going to do about it. So while we tend to see some of this stuff more so in AKT in terms of knowing organism versus treatment, here we want to apply it to this specific patient condition. And this is an interesting one because it really depends on which guidelines you're used to using, because we actually have the two options here. We have oral metronidazole, which you don't need to know doses, but for your own information, 400 milligrams orally with food twice a day for 7 days, or 2 gram orally with food as a stat single dose. Or you can use oral tinidazole, 2 gram orally as a single stat dose as well. Which one you would choose to do, I think, would be based on patient preference, patient condition, compliance, risk of compliance concerns, and local guidance as well. If you happen to know what the local microbiome is doing, it may sway your answer. So if you were to go with therapeutic guidelines, which tends to be the kind of gold standard most people follow, you'd have the option of either or. If you're going just by Australian STI management guidelines, really it just pushes the metronidazole. So there you go. Let's have a look at the chat here. So we have 2 gram of Zithro. Will kill pretty much everything else we deal with in terms of STIs, but unfortunately won't do the trick for trike. Good guess though. And here we've got oral metronidazole, 2 gram as a single dose. Fantastic. Love that one there. Excellent. And sneaking in there from Nita, metronidazole. Fantastic. Very good. And for this one, again, if you want to be really nitpicky, specify oral metronidazole, because it can be given in different formulations as well. I mean, let's be honest, we're only going to be using it as oral for this patient here, but if you just want to make sure you cover every base and get as many marks as possible. All right, so that is case number 2 down. Well done, guys. Awesome responses in the chat there. We have a final case prepared tonight with 3 questions to it. Hopefully, you're happy to just crack on, keep on with these. I'm really loving the answers we're getting through, though. Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at the answers. Admittedly, this is a question that you probably wouldn't get in the actual exam. The wording of it's not fantastic, but really what we're looking for is what are the things we would look for secondary to fracture? What are the things downstream of that we're going to be worried about occurring? And so the big thing really is that neurovascular compromise. So the absence of radial pulse in the affected arm, or you could just say distal pulse, Signs of ischemia or pallor in the hand would be lumped into that. It's really a perfusion kind of thing. Likewise, cool temperature of the hand as well would kind of get lumped into there. Severe swelling in the forearm or elbow, suggesting compartment syndrome. So what are we looking for? What are we concerned about? Skin puckering or dimpling over the elbow. Again, concerns around that compartment syndrome effect. Anterior bruising at the elbow, signs of hemorrhaging into that space. And of course, evidence of neurological injury, weakness or paresthesia distal to the injury. Wording of that one's a bit shoddy, we'll say, sorry. But really anything that kind of specifies we're looking for that altered nerve activity distal to the injury site. Each of those things is going to be worth lots of marks. This is one of those things, it's a red flag question where they're wanting to know, do you know the dangerous things to be looking out for in a patient in this position, especially a case like this where this is a not uncommon presentation. Now take note as well that this is presents to the emergency department, so consider the work site in your answers as well, and that might be a bit more relevant for upcoming questions as well. So looking in the chat here, we've got left pinky cap refill under 3 seconds, left pinky tip numb to light touch. So we've covered vascular, we've covered neurological, left into digital power 2 of 5. So again, probably a bit of overlap there in terms of really they're both kind of nerve type responses. So I'd try and diversify a little bit if you can. And probably use something more like the skin condition or swelling, puckering, those kinds of things there. But otherwise, fantastic answers. Excellent. So, what could come next, I wonder? The fact that I've had the Royal Children's Hospital up there for fracture management, I think most of you can probably guess where this is going. So, let's get 2 minutes on the clock for the next question. Your time starts now. All right, so let's have a look at those answers. Of course, there's always going to be some kind of interpret this ECG, X-ray, clinical photo type question, and they try to find photos where it's going to be relatively obvious what the actual thing is, bearing in mind that these have to be physically printed out and delivered to sites all across Australia. The print quality is not always the best, and so they have to try and take that into consideration and find things that aren't going to trip people up too much. So if you want full marks here, this is a Gartland 2 supracondylar fracture of the left humerus. So that will get you 3 marks. We've said what it is, where it is, the grade of it as well. You could just specify a supracondylar fracture of the left humerus, getting 2 marks, or just supracondylar fracture or humeral fracture, 1 mark. So depending on how much detail you put into there, And we can see here, this is a case taken from Radiopedia. If you're not familiar with Radiopedia, become familiar with Radiopedia, just like things like DermNet as well, if you're not using it. They have heaps and heaps of cases up there that you can practice, test yourself on, I mean, let's be honest, it's where RACGP gets a lot of their photos from for the exams, these kinds of sources. So the more you're using it, you may be surprised what pops up in the actual exams as well. Everyone that uses DermNet has giggled when they've seen photos pop up in the exam. They're like, yep, okay, I know what this is, not because I know what this is, but because I've seen this photo before. Excellent. Now you can see here from the radiograph when they've drawn the green line of doom here, which is actually showing that posterior displacement, the angulation of the fracture there of the distal humerus, the supracondylar. Here we go. We have from Beba a type 3 subcondylar fracture of the left humerus. And you know what? I think you would actually get the marks for that as well. Given on this photo here in particular, printing and screens taken into consideration, I think they would give that. There is just that little bit of cortical contact just at the distal posterior section. Admittedly, it's not much. So technically it is 2, but I think they would give you full marks for 3, given the quality of the radiograph provided. So very well done, mate. Very, very well done. Excellent. So we have one final question on our last case. Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some of those answers then. So first thing, of course, is to take into consideration this is a kid with a fracture, so we want to be providing some kind of analgesia, some kind of pain relief. Now, it has specified vital signs are normal, so you can hope the pain's not too severe. So I think as long as you're giving some kind of sensible option, like oral ibuprofen or paracetamol, something in that kind of territory to start off with, this is immediate management, I think you'd get the marks. You also want to be immobilizing this left elbow with a back slab in 90 degrees of flexion. So we're specifying what we're doing, which side, and how we're doing it. So back slab, 90 degrees of flexion, full marks there. There's going to be a referral for urgent orthopedic consultation for fracture management. So the urgency, who it's to, what it's for. Elevate the arm to reduce swelling / prevent compartment syndrome. Now, if you were to put that exact sentence in, you would be losing marks. That's definitely overcoding. So I think as long as you're putting something in that kind of territory, you would get a mark. And of course, perform and document a thorough neurovascular assessment pre and post immobilization. You might get a mark there. I always try to throw something like this in to say you're acknowledging how good or bad it could go. So you need to document pre and post. The thing that mucks this up, for this question at least, is the immediate management. So that might be more kind of medium-term management in terms of documenting pre and post, but I think you might, at a stretch, get a mark in there if you can't think of anything else. Let's have a look at the chat then. So here we've got immobilization. Good, I'd probably get a little bit of more information into there. External reduction. To be honest, if it was me in ED, yeah, I probably would, to be honest. I agree with you there, just given that level of movement. I think if we're looking at it from a GP perspective, average GP working in ED, they might be happier to just say refer to orthopedics to do that. But if you've got the skill set and experience, I think it's something that an experienced GP with experience in orthopedics could also perform as well. Diclofenac injection for pain relief. You know what? Yep, fantastic. And diclofenac is a brilliant analgesic that I think a lot of people actually figured about. So, yeah, look, I think while I've gone the oral route, I think it's not a terrible choice for this kind of patient there. So, well done. And we've got a little note from Kesh. Hey, Kesh. Back for revision. Of course, you can't hold me back. I'm always going to cause mischief. Excellent. So, hopefully you're happy with those answers. I can see most people seem to have put in things pretty similar to that, so fantastic to see. That was our final question for tonight. So well done. Congratulations on getting through. I know there's probably other places you'd rather be on a Wednesday night at 9:30 p.m, but I'm really glad that you've chosen to spend this time doing some of these practice questions. Hopefully you've already started to kind of catch yourself on some of those traps a lot of people find themselves in. Of course, if you do find this helpful, please tell people. I've gotten here, I do it for 12 weeks before each KFP exam. We did run a little bit late with some of the CCE practice, just to the timing of those sessions, and so I'll be doing them weekly until the KFP exam as well. Tell other people, the more people we have in here, the more people contributing their answers, the more we can tease apart good ones, things that need more work as well. So feel free to invite others to the party. And of course, I chop these up and post them in as other shorter videos for you to practice on. If you want more questions to practice on, you don't have to pay for question banks. I do have in the channel a whole bunch of other ones in there as well. I'll be honest, I write these questions myself. I do have some limited time, so they're not all fantastic questions, but again, focus not just on the answers, but the formatting of the answers. Those are the things that I think trap most people up, and so use these as tools to practice that as much as anything else. So those are the questions I had prepared for tonight. I'm going to hang around here as well. I can see Kesh and Demir having a bit of a chat as well, and I might join in on that. If you guys wanted to otherwise head off though, thank you all very, very much for jumping in tonight. I will otherwise catch you next week, where we'll have another 3 questions loaded up to practice, counting down. You guys are going to smash the KFP exam. It's just a matter of putting the work, putting the head down, getting through, practice as many questions as you possibly can, and of course, general practice, general perfect. It's cheesy, but I love it.